in this series of webinars which we have designed for decoding primary immunodeficiency disorders. These disorders, as we all know, we've heard over the last 4 weeks, and we are past the halfway mark. Can I have the next slide, please? Today, Dr. Amrita and Dr. Kirtivardhan are joining me as we take you through 3 diseases today, and which will come under the congenital defects of phagocytic function and defects in intrinsic and innate immunity. And as a reminder that the latest classification is the 2022 update on made by the International Union of Immunological Societies Expert Committee. And as of date, we have more than 400 inborn errors of immunity, which have been classified under these chapters. And the challenges remain of trying to identify them from the large stack of phenotypes which is available, to must make sure that you are thinking of an inborn error of immunity, and then proceed in a kind of screening whether they are really present or not. And if you have a suspicion which is not yet confirmed by screening tests, then how do we move forward? We've been covering different aspects of this diagnostic challenge in the last few webinars, and we'll take you through a few more of this today. Can I have the next slide, please? So today, first, I will be talking about chronic granulomatous disease. So as you can see here, the CGD is basically a defect in the enzyme NADPH oxidase. This enzyme is present in neutrophils, monocytes, macrophages, and eosinophils. And when it works well, then it leads to the production of superoxide anions and reactive oxygen species. And it is these molecules which help to kill the microbes. And once this is fully functional, then this part of the innate immunity is responsible for clearing many organisms without the need of the humoral arm. So can I have the next slide, please? This important enzyme, the NADPH oxidase, which is present not only in the neutrophils but in other cells, as I said, is composed of many subunits, basically 5 subunits, and 4 of these are demonstrated on this slide here. The 5th one is not demonstrated because only one case has been described where deficiency of that 5th subunit has led to a chronic granulomatous disease. So if you can see here that the blue stacked boxes, they are on the membrane, and they belong to 2 molecules, the GP91 FOX and the P22 FOX. These are the transmembrane portions of the NADPH oxidase. Now within the cytosol, we have the 3 others, that is the P47 FOX and the P67 FOX. The chronic granulomatous disease most commonly arises due to mutations in the GP91 FOX. And if you can look at the small, basically it's a ferricytochrome oxidase. So you have the iron molecule in the center depicted in the transmembrane region. And you have those other pink and yellow circles which represent the mutations which have been identified in various patients across the world in this particular GP91 FOX. So this GP91 FOX is basically, can I have the next slide, please? Is basically a X-linked inheritance, and it is coded by the enzyme cytochrome B, and it is the beta polypeptide of cytochrome B, and it is by far it is reported to be the commonest, but a lot of studies from India and other parts of the world say that the cytosolic subunit of NADPH oxidase, which is coded by the gene neutrophil cytosolic factor 1, and codes the protein P47 FOX and is inherited as autosomal recessive, is also very common. Others are much less common. And next slide, please. So how do patients with chronic granulomatous disease present? So most of these patients present with recurrent bacterial or fungal infections. And this, as you know, is the presenting manifestation of any inborn error of immunity. But what is important about chronic granulomatous diseases, that most of the infections are basically pneumonias And this is important that up to 80% of patients present with pneumonias. Most of these are bacterial pneumonias, but they also can be fungal pneumonias. These patients often present with infections in the skin, which can be deep infections. They can also present with abscesses, which can be visceral abscesses, like in the liver or in the kidney. And they can have infections in the bones. Next slide, please. They also have a lot of inflammation, and these inflammations usually take the form of granulomatous lesions. And sometimes the diagnosis of chronic granulomatous disease is informed or is suspected when the granulomas show pigmented histiocytes or eosinophils. So sometimes a pathologist or a clinician who is reading such reports can start thinking of CJD when granulomas which have lipid-laden histiocytes or pigmented histiocytes along with eosinophils are seen. Now, inflammation happens in chronic granulomatous disease and can also present as inflammatory bowel disease, uveitis, and occasional patients as a discoid lupus erythematosus lesions. This inflammation and recurrent infections leads to a chronic malnutrition, which is manifested as a short stature and underweight patients. And a lot of these patients have a premature death because of these complications, and the death rate is almost 1 to 5% every year. Next, please. So why do granulomas happen specifically in this disorder? Because normally these reactive oxygen species, they clear the microbes. So when these microbes are not cleared, then the ongoing inflammation leads to a lot of cellular infiltration, fibrosis, election of histiocytes, and granulomas happen. So the whole process is an effort to contain microbial infections. Next, please. And these granulomas can often lead to obstructive symptoms also. So if you see patients with pneumonias and granulomas, then you should be thinking of CGD. So we had a case, a 4-year-old child who was born of non-consanguineous marriage, and till 3 years he was fine, and then he started developing fever, cough, and tachycardia. And within 3 days, he had a right mandibular swelling, which progressed to necrosis, was covered with a black slough. He also had bronchopneumonia at that time. And this mandibular swelling went on to become a necrotizing fasciitis, requiring a lot of surgical intervention, but which healed with secondary intention and left a lot of hyperpigmentation and scarring. His 7-year-old brother was normal, and the screening investigations showed that he had anemia, leukocytosis, mild thrombocytosis, and there was a shift to the left. Now, this itself was enough to suggest that there could be an inborn error of immunity, despite the fact that this was a single infection, because it was a two-site infection and it was very severe. So, the lymphocyte subset analysis was normal. The CD3, CD4 counts were normal. CD8 was normal. B lymphocytes were normal, and the NK lymphocytes were also normal. Next, please. So the next screening test for patients where you suspect an IEI is a DHR assay. Now, if you look at this slide here, then this is showing us a DHR assay. DHR stands for the dihydrorhodamine assay, where the dihydrorhodamine is oxidized by a normally functioning neutrophil. And so there is a shift in the fluorescence, which is gated. So here, if you see on the left panel, I'm showing the control. In the left, the leftmost red is the unstimulated peak of the neutrophils. And on the right of this is the stimulated peak. So if you can see that the fluorescence intensity peak has shifted in this control patient who is normal. If you look to the panel on the right, which shows a patient, then you see that the shift in the red peak is very little. And if you look at the report, then the patient's stimulation index, which is just a ratio of the stimulated by the unstimulated mean fluorescence index, is 2, while the controls is 118. And if you look at the control ranges mentioned, then this is highly pathological. That means the patient is unable to really generate oxidation of the dye, and hence is deficient in the NADPH oxidase enzyme. Next, please. So there are other tests also. DHR has now become a screening test, with flow cytometry. However, in the past, for many decades, laboratories in low resource countries used to do the nitrobrew tetrazolium test, where the pale dye, that is nitrobrew tetrazolium, is initially a pale colored dye. If it is taken up by normal phagocytes, then it is oxidized and you get a dark blue color. But if the enzyme is not present, then it remains pale. If you have a carrier, that means you have some neutrophils which have the oxidase activity and some which don't, then you can have a mixed population like this. The problem with this test was that you needed to have severe chronic granulomatous disease. That means you needed to have almost absent activity of the enzyme to be able to have a positive NBT test. And over the years, this has gone out of uh, you know out of focus in tertiary centers, and DHR has now become the screening test for chronic granulomatous disease. Also, the components of the enzyme, the GP91 FOX, the P47 FOX, they can be assessed by intracellular staining, where the cells, the neutrophils are permeabilized and the dyes are then sent into the cells. And these subunit antibodies against GP91 or P47 help us to see whether these are present within the cells or not. So this is a representative image, which basically in this article, they built up an assay for these intracellular components of NADPH oxidase. And if you can see that patients with deficiency of GP91 or P47, they have much lower ROS production. This is on the left panel here, and the carriers have a slightly higher production of oxygen here. And if you look at the MFIs on the right, then the healthy volunteers show a good shift of the mean fluorescence index, while the CGD patients, GP91 FOX, they have no shift at all. Carriers have a little shift. And same thing happens with P47. Here, if you can also see that the P47 FOX CGD patients, they have a kind of a less high peak and a broad base. This suggests that the activity of the enzyme is not as badly affected as in GP91 FOX. And it is usually seen that if you get this kind of broad-based flow picture, then without a genetic test, you can say that this patient who has CJD is probably going to have a P47 FOX mutation, and they have a better survival. There is an elegant study which shows that the survival of patients with CJD is directly proportional to the amount of enzyme that they produce, residual enzyme activity that they have. So what happened to our patient? The DHR was definitely positive, and the genetic test also showed us that there was mutation in NCF1. Now, while there was a homozygous mutation, which means that the parents would have been carriers. So while we could not do the analysis in the parents, we, based on the DHR and based on this, we are reasonably sure that we are diagnosed a case of autosomal recessive chronic granulomatous disease. Next, please. So there is already data from India published in 2021, where patients from around 10 centers were collected onto an Excel sheet. And in this, from this data also, they showed that the autosomal recessive CJD, which is basically either due to P47 or 67 or 22, is commoner than X-linked CJD, but X-linked CJD is also quite common. And like in our case, the NCF1 mutation patients are quite large in numbers, and so is the X-linked CJD. So we are happy that at NIMS, we are able to do the DHR flow assay. And I think that we could probably be collecting more cases and diagnosing them earlier if we keep our threshold for suspecting these lower, and especially in patients who have some granulomas and history of infection in the past. Next, please. And so the differential diagnosis of CJD is actually quite large, and it could even resemble cystic fibrosis. It's very interesting that along with NADPH oxidase, the G6PD molecule also helps in the function of NADPH oxidase. So a severe G6PD deficiency can produce a picture very similar to CJD, and you could have granulomas and infections in other diseases which are listed here. So if you look at sarcoidosis, it is also granulomatous disorder. Crohn's is also a granulomatous disorder. And so when you find a granulomatous IBD, especially if you find a very early onset IBD, which is called EOIBD, then you have to start thinking of IEIs, and in them, CJD will be a differential diagnosis. Next, please. So the treatment options include prudence, that is prevention with prophylactic antimicrobials, especially like cotrimoxazole, and antifungals, surveillance for infection actively. Some centers advocate the use of interferon gamma, but it's not available in India. Adequate immunization and avoidance of prudence by avoiding risks like exposure to swimming pools which are not well maintained, etc. Next. The definitive treatment in CJD is allogenic hematopoietic stem cell transplantation. And if patients, and actually, there's a lot of activity in this field, because if you understand, if you know how your patient is, if you know the mutation, if you know the residual NADPH oxidase activity, then it is up to the clinician to decide how urgent is the need for allogenic hematopoietic stem cell transplantation. So with this, I'll take you through the next disease, which is planned for today. That is the Mendelian susceptibility to mycobacterial disease. Basically, this is a disease this is a constellation of diseases or clinical phenotypes, which is due to defect in the IL-12, 23, ISG15 interferon gamma pathway. So in these patients who are otherwise absolutely healthy, they will have selective susceptibility to mycobacteria of low virulence, like that which is seen in the BCG vaccine strain, or the environmental non-tuberculous mycobacteria, and other like salmonella, fungi, parasites, etc. So this slide is basically a collection of 830 patients with MSMD. It's a review. And what I wanted to show you here is, if you can see at the background the global map, then the darker areas are the areas from where a lot of MSMD has been reported. And you can see that from India also, a lot of cases of MSMD have been reported. This is not surprising because we are endemic for tuberculosis. But when do you suspect MSMD in a patient with tuberculosis? Uh, Before I tell you that, basically the clinical features here, the commonest is lymphadenopathy, and often it is multifocal. So again, the differential diagnosis becomes very broad. The axillary lymph nodes are quite often affected. Patients can present with only fever. Patients present with, especially following the universal vaccination that we have in India, they can present with BCG infection, which can be either local, that is a BCG itis, it is called, or it can be disseminated tuberculosis, which is called BCGosis. Either of these two can happen. Another very common presentation is osteomyelitis. Most often, the osteomyelitis is multifocal. So you could, when you see a child who is having multifocal osteomyelitis, then whether or not you have the organism identified, you should be thinking of MSMD and you should be trying to prove the organism, which anyway is good clinical practice. Other clinical features are also listed here, like anorexia, respiratory symptoms, some autoimmune diseases, and abscesses. So generally, these patients present immediately after the vaccination with the local lymph node in the axilla or in the neck, and sometimes with disseminated tuberculosis. So, as I said, this is basically a defect of the IL-12, 23, ISG15 pathway. So, when the mycobacteria come into the body, then the macrophages, they engulf the mycobacteria. And once this happens, then a lot of IL-12 is produced. This IL-12 works through its receptors, the IL-12 receptor, which has two polypeptides, beta 1 and beta 2, and then acting via the JAK2 and the type 2. The beta 1 is attached to type 2 and the beta 2 is attached to JAK2. They activate the T lymphocytes. Now, IL-23 pathway also acts through these receptors, which one of which is common to IL-12 also. And once the T cell is activated, the interferon gamma, which is produced, acts through its receptors on the macrophages, that is the interferon gamma receptor 1 and gamma receptor 2, which is present on both T lymphocytes as well as macrophages. And then the JAK1 and JAK2 attached to these receptor 1 and receptor 2 of interferon gamma works through STAT. And this interferon activating factor complex leads to production of a lot of genes which are responsible for containing the mycobacteria. In this pathway, many mutations are described, and some of them lead to isolated MSMD. That means all those proteins which you are seeing here marked in red, that means the IL-2 receptor beta 1, beta 2, the interferon gamma receptor 1, receptor 2, and the IL-12p40 interferon gamma by itself. These will produce defects in these will produce isolated MSMD, but defects in other molecules in the pathway like JAK1, T beta, ISG15, ROR gamma T, and the ZNFX1, they produce syndromic MSMD. Syndromic MSMD means you not only have infection with either mycobacteria or salmonella, but you may have an additional feature, which could be like hyper IgE, or you could have viral infections, or you could have autoinflammation, things like that. So specifically, the ZNFX1, which is on the left side here in the macrophages, this actually guides the ISG for containing viral infections. So defects in this molecule lead to an MSMD with viral infections. Next slide, please. So I will describe a case here. So this was a child, 6 months old, who at 2 months had an axillary swelling and with pus gestalt with healed with medication. At 3 months, he was still having tenderness in the left axilla, but he now developed swelling in the left second digit, progressing to the right second digit, other digits, and lower limbs. And he started having fever and has some setback in his development. There were no family history of any similar infections. He had anemia, leukocytosis, thrombocytosis, and X-ray showed periosteal reaction in the multiple metacarpals and upper ulna, suggesting that there was an osteomyelitis going on. And the ultrasound confirmed these findings and also suggested a splenic granuloma. He had elevated acute phase reactants, low head circumference, but the screening tests, the immunoglobulins, and the dihydrorhodamine test were normal. So we had osteomyelitis here. We definitely were thinking of IEI. And we had normal immunoglobulins and DHR. So can I have the next slide, please? So I'm just putting the screening tests here together first. So if you suspect MSMD, we did not suspect MSMD here because we hadn't proven any tuberculosis, but we knew that there was an inborn error of immunity here. So if you're thinking of MSMD, suppose you have an organism already knowing that it's a salmonella or low virulence mycobacteria or a non-tuberculous mycobacteria, then apart from the basic lymphocyte subset, the NBT test or the DHR test, the immunoglobulin levels, you will start looking at flow cytometry for interferon gamma receptor 1, interleukin 12 receptor, the beta 1 polypeptide, which is called CD212, the STAT1 and the STAT4 phosphate molecules. Now, the STAT1 and the STAT4, they are intracellular, and the IFN gamma R1 and the IL-12 R beta 1, these are surface molecules. We could also do serum interferon gamma levels, but flow cytometry and NGS, they usually help us to make a diagnosis of MSMD. So in this case, after we thought of IEI, because we did not have the flow cytometry set up for this pathway, we went for an NGS and we found that the patient had a variant in the STAT1 gene at exon 23. Now, if we can recap that this patient has had an osteomyelitis and possibly a BCG site, vaccination site adenoma, and a STAT1 deficiency, then at the moment, without confirming this in parents or without showing flow cytometric evidence of impaired pathway, the interferon gamma IL-12 pathway, we will say that this child probably has MSMD. Next slide, please. So, MSMD data from India has been collected and published in 2021. And as you can see, the complete, there are many, bits of the pie here. So if you can quickly look at most of them are referring to complete deficiencies of either IL-12, RB1 in green, or the red and the light blue are the interferon gamma receptor 2 and receptor 1 deficiencies, which by far make up most of the pie here. But you could also have partial deficiencies instead of complete deficiencies. And this is important because that also decides how sick the child will be, how urgent will be the need for the hematopoietic stem cell transplantations. So next slide, please. So if you have a complete deficiency of interferon gamma receptor 1 or 2 or STAT1, then hematopoietic stem cell transplantation is the only curative option. But if you have partial deficiencies, these childs are less sicker. So you might sometimes be able to get away by giving them interferon gamma lifelong. But at the moment, this is not available in India, but is used abroad. Next slide, please. So I will end here and I will pass the baton to Dr. Amirta. Dr. Amirta is faculty with us in the Department of Clinical Immunology and Rheumatology, and she will take you through the functional defects in neutrophils again, but this is of a different kind.
Thank you, ma'am. Good evening, everyone. So I'll be continuing with the next phagocyte defect, that is leukocyte adhesion defects. So leukocyte adhesion defects are a group of autosomal recessive inherited genetic disorders. They primarily affect the migration of neutrophils to the site of infection. So these are again very rare PIDs with an estimated prevalence of 1 in 1 million births. So a brief overview of the pathogenesis of leukocyte adhesion defects. So in a healthy person, the leukocytes are normally flowing in the blood in a laminar flow without sticking to the endothelium. Whenever there is some sort of infection or inflammation happening in the tissue, the endothelium becomes sticky and the neutrophils get activated and they start getting attached to the endothelium and eventually migrate through the endothelium and the basement membrane into the tissue. So this is a series of orchestrated steps which happens, and this is known as neutrophil migration. So the first step in neutrophil migration is a loose adherence of the neutrophil to the surface of the endothelium, a process known as tethering or rolling. And this is mediated by molecules expressed on the surface of neutrophils called the P-selectin or the L-selectin. And similarly, the E-selectin is expressed on the surface of the endothelium. So the selectin molecules will bind to their ligands. So these ligands actually express very high levels of a carbohydrate moiety called the sialyl X Lewis X. So this sialyl Lewis X is quite critical for effective binding of the selectin to its ligand. So once the neutrophil has loosely bound to the endothelium, the next step is a firm adhesion, and this firm adhesion is mediated by molecules known as integrins expressed on the surface of neutrophils, which will bind to molecules called ICAM or VCAM on the surface of the endothelium. So integrins are crucial in the pathogenesis of leukocyte adhesion defect. LAD1, the most common and the most prevalent form of LAD, in that there is the main defect is in the integrin. So once there is a firm adhesion of the leukocyte to the surface of the endothelium, eventually there is a transendothelial migration. There is a perforation of the basement membrane, and this basement membrane penetration is called diapedesis. And this is mediated by molecules such as, the PCAM integrins or the PCAM and the VCAM. So I would like to talk a little bit in detail about the integrins. So the integrins are heterodimers which are expressed on the surface of all human leukocytes. The heterodimer has an alpha subunit and a beta subunit. There are around 10 alpha subunit families and around 7 beta subunit families. And with different combinations of alpha and beta, there are around 25 different heterodimers of integrins in human leukocytes. So of interest to us in leukocyte adhesion defects are these four on the left side of the slide. So LFA1, MAC1, VLA4, alpha 4, beta 4. So the alpha subunit of these integrins are labeled as CD11A, CD11B, and CD11C respectively, and the beta chains are labeled as CD18. So normally in a resting leukocyte, the integrin is in an inactive and low affinity state. So when there is a stickiness of the endothelium, the inside-out signaling of the integrin kicks in. This is mediated by a protein called kindlin. And once the kindlin gets activated, the integrin becomes active and it goes into a high affinity state. So I'll be describing a short case here. So this is a 4-day-old male child who presented to NIMS with history of fever from the first day of birth. On examination, he had a tender scrotal swelling. He also had a swelling in the posterior aspect of the left ear, which was extending down to the lower jaw, and this was suggestive of a neonatal osteomyelitis of the jaw. So what was striking was a very high WBC count of 33,000. So with the diagnosis of sepsis and a blood culture showing Pseudomonas, he was treated with IV taxane and vancomycin. However, after a week, we saw that the total leukocyte count continued to rise and went up to 65,000. So it was a predominant neutrophilic count. This child also had a delayed fall of the umbilical cord on day 21 of birth. So in this setting of a neonatal sepsis, there is a suspicion of an inborn error of immunity, and hence we went ahead with testing serum immunoglobulins, which were normal, and also a lymphocyte subset analysis where CD3, CD4, CD8, CD19, and the NK cell markers were all within normal limits. So the next step in the evaluation was to do a flow cytometry with a suspicion of a neutrophil defect. So this is a flow cytometer of a control on the left side of the panel. A forward scatter and the side scatter, we have been able to get the neutrophils. So if we look at these boxes here, in the control, 100% of the neutrophils are expressing CD11A and CD18. So if you recollect from the earlier slides, CD11A represents the alpha subunit of the integrin and CD18 represents the beta subunit of integrin. So 100% of neutrophils of the control are expressing both the molecules. Similarly, 100% are expressing CD11C, 11A, as well as CD11B. So if you look at the right side of the panel, that is a child's flow cytometer, we can see that none of the neutrophils are expressing CD11A or CD18. Similarly, 0% of the neutrophils are expressing 11C or 11A or 11B. So this child has a complete absence of CD11A, 11B, 11C expression and CD18 expression on the surface of neutrophils. So this is the classic setting of a leukocyte adhesion defect, and this is type 1. So what are the clinical scenarios when to suspect LAD? So the typical age when LAD presents is in infancy. Usually most of the children are diagnosed within the age of 3 years. Children present with recurrent bacterial infections, predominantly involving the skin, pneumonia, otitis media. Children with a milder form of LAD in the pre-pubertal age group also present with severe forms of periodontitis. One classic history that we would get in LAD is a delayed separation of the umbilical cord, that is separation beyond the 14th day of life, and an associated infection, omphallitis. Delayed wound healing is also very notable in these patients. And since there is a defect of neutrophil migration to the site of infection, there is generally an absence of exuberant pus formation. And as in any autosomal recessive condition, parental consanguinity is also a clue. So next I'll be talking a little bit about each of the LADs. So we have four forms of LAD. The most common, the most prevalent form is the type 1. So more than 95% of patients diagnosed with LAD have the type 1. So the classic defect in type 1 is a decrease in the beta 2 subunit of the integrin, also known as the CD18. The mutation is seen in the ITGB2 gene. So what is affected is the firm adherence of the neutrophil to the endothelium. And this LAD1 is characterized by recurrent severe forms of infections in infancy. And as described earlier, LAD1 classically has delayed separation of the umbilical cord, severe periodontitis, and a significant leukocytosis in the absence of pus formation during infections. Children with LAD1 also exhibit a degree of autoimmunity. So most of these children may be positive for antibodies like ANA-ANCA, though clinical autoimmunity is quite rare. There is definitely a heterogeneity among the severity of infections in LAD1 patients because this is quite proportional to the extent of beta 2 integrin deficiency. So some pictures of children. So this is another 4-day-old child who presented to NIMS in 2016. The child came with fever and cellulitis of the nasal bone, and again severe leukocytosis, and there was history of delayed cord fall in this child as well. The lymphocyte subset analysis and serum immunoglobulins were normal again. And with the help of flow cytometry, we were able to diagnose with LAD. However, the child expired at 3 months of age because of severe sepsis. So these are some more pictures from literature. So we have a child with a perforating palatal ulcer, a severe abscess, a non-healing abscess in the nape of the neck, and a prepubertal child with severe forms of periodontitis. So how do we diagnose LAD1? So as demonstrated earlier, the first investigation of choice would be a flow cytometry to demonstrate absence or a deficiency of CD18, which is the beta subunit, and an associated deficiency of the alpha subunit, which could be 11A, 11B, or 11C. So in severe forms of LAD1, less than 2% of the neutrophils would express CD18. If 2 to 13% of the neutrophils are expressing CD18, we would consider it a moderate type of LAD1. A confirmatory test would be detecting a mutation in the ITGB2 gene. So moving on to LAD2. So LAD2 is a milder and a very rare form of LAD. So here the defect is in the selectin ligands. So the selectin ligands have the CLL Lewis X, which contains a glycoprotein moiety, and there is a defective fucosylation of the selective ligands. The mutation is often detected in the gene SLC35C1, and the initial part of rolling and tethering of the neutrophils to the endothelial surface is affected. So LAD2 patients generally have milder infections. However, these children generally do not have impairment of wound healing. So two characteristic features in LAD type 2 is a presence of mental retardation. And since the fucosylation is also required for blood group, for blood types, Bombay blood type is also quite frequent in these patients. Excuse me. Flow sorry. uh, sorry for that. So flow cytometry to detect CLL Lewis X, that is a CD15, is on the neutrophils, is diagnostic for LAD2. So the third form of LAD3 is when, I'm sorry. Um,
Amita, you can have a glass of water and come back.
yeah, this. So the third form of LAD3 is because of a defect in the kindlin 3, which is required for the inside-out activation of the integrins. In these children, again similar to LAD1, there can be severe infections in infancy, and because the kindlin defect can also affect platelet activation, these children often present with severe bleeding diathesis. The fourth type of LAD is where there's a mutation of the CFTR gene. So here there is a decrease in the beta 2 as well as the alpha 4 beta 7 integrin. In these children, there is a defect in the monocyte lymphocyte adhesion. However, the neutrophils are generally spared. These children have a cystic fibrosis like phenotype. Sorry. So this is again a spectrum of a large cohort. Ma'am, I'm sorry. Can you take over?
So the Indian data, I'll basically be reading out from Amrita's slides. So the data on LAD from India, these are not very common disorders, as Amrita said. So the disorder, so again, the centers which work on immunodeficiencies, they are listed on the ISPID website. And in LAD, 132 cases have been described till now. While the LAD one is the very celebrated phenotype where, a delayed fall in umbilical cord is easily picked up by pediatricians. And if such a child develops an infection under their care, then it's not difficult to look for LAD. But as Amrita said, the other two phenotypes are milder, and so they are likely to be missed. So their definitive diagnosis will be only made when you are doing flow cytometry, and flow cytometry for LAD was done in very few of the centers in India. The best centers being the KEM and the PGI Chandigarh. Even in those centers, these tests are done by appointment. And so, if you can see from the three kind of diseases that we have presented, uh, patients with MSMD may present actually even in adulthood, but the literature from abroad says that they usually present in childhood. But data from India has shown that patients with MSMD present as early as 5 to 6 months of age, because BCG vaccination is universal in India. If you look at LAD, then these are again very young infants who present with disease. Uh, Patients with CJD can be older. So LAD is a diagnosis which neonatologists will make. Uh, Mutations in the genes, the integrin genes, beta 2, and the FOMT3 genes, these are 35 have been described till now. But as we know by reading literature on IEI, novel mutations are always described, and especially with the availability of NGS now, uh, sometimes even unusual phenotypes give up diagnosis like LAD and MSMD, and are reported by by these companies who run the NGS as variants of uncertain significance. But again, knowledge of the phenotype of the patient is so important that even if you get a report of variant of uncertain significance, it becomes the responsibility of the clinician to try and match the phenotype to the discovered either VUS or pathogenic variant, and take the treatment of patients forward. We've actually moved from a we moved from a point where we were happy to just diagnose these disorders to a point now in our institute where we are able to make molecular diagnosis better, to a point where we are now going to be doing functional studies on variants of uncertain significance so that we can understand the pathophysiology of these disorders better. Um, the where about what is happening in India is that curative hematopoietic stem cell transplantation is happening in centers like Bangalore, PGI Chandigarh, and in Mumbai. And a lot of these patients with MSMD, CJD are surviving with hematopoietic stem cell transplantation. And even in LAD, this is being used. These are very, uh, these are procedures which require a high degree of expertise and a lot of reliance on the exact preconditioning regimes that these children can be exposed to because they are already immunodeficient. And so this is available in only a few centers. Is there something else that you would like me to say, Amrita?
No, ma'am. Sorry for the interruption. So some of the differentials for leukocyte adhesion defect are the other neutrophil disorders that ma'am has discussed in the last 1 hour. So one is chronic granulomatous disease, other could be hyper IgE syndrome. So all of these disorders have abnormal chemotaxis or an abnormal respiratory burst, but they can be differentiated based on the clinical phenotype and of course by our molecular biology techniques. So the management of LAD, like any other PID, can be quite challenging. So these children require antibiotic prophylaxis, very prompt and aggressive treatment of their infections, good oral hygiene and skin care. And like most of the PIDs, allogenic bone marrow transplantation would be curative. The survival is around 75% at 5 years in matched donors. So with that, I'll conclude. Thank you.
Thank you, Dr. Amrita. Dr. Kirtivadan.
Uh, uh, Thank you, Dr. Lisa ma'am, Dr. Amruta, for your thoughtful insights on CGD, MSMD, and LAD. And thank you to viewers also. They have enthusiastically posted many questions. So we'll go one by one. So the first question would be to Dr. Lisa ma'am. What are the other antibiotic prophylaxis option other than quatrimoxazole in patients with CGD?
Uh, so there is no well laid down guidelines, but cotrimoxazole is considered to be the antibiotic prophylaxis of choice. If you have a child who is showing you specifically a particular infection, then you could consider other things like uh, amoxicillin, clavulanic acid. But there is no particular guideline because the world is moving towards considering definitive therapy in these disorders.
Okay. So the next question would be, what is the prognosis in patients of CGD? That means average lifespan.
So actually, some patients can survive adulthood also. As I said, that in 2010, the Stephen Holland's group, he's the major scientist who works on CGD, and what they showed was that the survival depends not on the type of mutation directly, indirectly it does, but it basically is directly proportional to the amount of residual NADPH oxidase activity present in the neutrophils. So if you have say 50% reduction in NADPH oxidase compared to 80% reduction, then the person with the 50% enzyme will live longer than who has 20%. So survival is, if a person has CGD, then the chance of death is like 5% every year. And but most of them don't survive like normal population.
And how common CGD have SLE like presentation?
So very rare, but like autoimmunity is described in up to 40% of patients, but most common is IBD. Occasional patients will have, so if you have a young child with a lot of DLE and maybe you have some colitis going on, then you'll be thinking of CJD.
Okay. What are the other IEIs that we have to suspect when a child has BCGosis after BCG vaccination other than CGD?
Other than MSMD. So MSMD is the first thing that you will think of, but you could also have, patients with chronic granulomatous disease also can present with BCGosis. That is because, the GP91 Fox is also a part molecule which is involved in killing the intracellular bacteria. As I showed you in the diagram, even monocytes and macrophages have it. So if it is deficient, then you could have MSM, you can have a BCGosis also. So CGD and MSMD are two conditions to be thought about.
Can DHR be negative in CGD?
So if you have a very mild, like, one of the subunits, like if you have the P40 Fox, which is very low, then you might find a pretty almost near normal NADPH oxidase activity. And so the flow may not sh- reach the, lower limit of normal. At that point, you can falsely interpret it as a normal DHR or indeterminate DHR. But what is important is that the NBT test, as I said, was sensitive only to severe CJD, but the DHR is more sensitive. So it is very unlikely that in a good lab you're going to miss DHR in a patient with moderate to severe CJD.
And do neonates or infants have neutrophilic leukocytosis without infection?
Mm, I mean, neutrophilic leukocytosis of the kind that we saw here, 20,000, 30,000, 60,000. No, they don't have that in the absence of infection.
So, how can we treat a disseminated BCG infection?
So the treatment actually, if it is due to MSMD, it requires prolonged course of ATD. So 20 years ago, we would say that, okay, we can treat these patients, just keep on giving them the antituberculous drugs. And then, some people started supplementing that with interferon gamma. But now, I mean, hematopoietic stem cell transplantation is the option. So the treatment remains the same. Only thing is that you will have to give it for a very long time, or you may have to give it repeated courses, because these child, when untreated with curative therapy, they have recurrent episodes of tuberculosis.
And what is the next best test for CGD diagnosis after screening test of DHR?
The next best test is the NGS. Usually, it's a clinical exome. There is a little complexity in the molecular diagnosis of CJD, in that while the X-linked CJD, which is the GP91 FOX deficiency, is picked up, you could have a problem in detecting the P47 FOX because the gene, the NCF1, it also has pseudogenes. So there, once you have pseudogenes, which are not, I mean, if they are picked up, then you may falsely say that your NCF1 is normal, but you're actually picking up NCF1 beta and I think gamma. So um, there you'll have to go beyond clinical exome. You'll have to probably do a Sanger for the NCF1 to show that it is a CJD. So DHR is kind of diagnostic, but it helps to make a molecular diagnosis also.
So, next question is to Dr. Amrita. How often umbilical cord separation is observed in LAD? Is it reliable?
So in LAD1, umbilical cord separation is often delayed, so reported in around 75 to 80% cases. And however, in the other forms of LAD, it's not very well described.
And the question continues, why is there a delayed cord fall in LAD1? If the neutrophils are unable to reach the site of inflammation, why is omphalitis occurring in LAD?
So, so infections, the typical redness and the warmth may be there, but obvious exuberant pus formation is what is absent in LAD. So other forms or other signs of infection like fever, redness or warmth is often detected, and that's what happens in omphalitis.
And next question is about this. This is like a general question. How to suspect fungal infections in infants and neonates? A CGD can have fungal infection and may need aggressive therapy.
So for the surface fungal infections, they are not difficult. So you can have patients with CJD who have chronic mucocutaneous candidiasis, and also in, like, if you remember the diagram, GATA2 deficiency patients, the which is a protein found in the nucleus of patients of macrophages. They can also have fungal infections. So mucocutaneous candidiasis is not difficult to diagnose, but fungus elsewhere requires, identification of the organism. Or I don't know if for those who were there in the mortality conference yesterday, uh, there are certain signs in the radiographs which can make you suggest like a fungal ball, or a bird nest kind of pneumonia, which can make you suggest that this is fungal disease going on. Otherwise it's difficult. Cultures are important.
Next question is to Dr. Amrita. What is the significance of association of Bombay blood group and LAD2? Why it is mentioned in LAD2?
So it's possible that the absent the H antigen, which is negative in Bombay group, is probably on the same chromosome. Usually it happens like that, but I'm not really sure.
So the fucosylation is required for the selecting ligand, and the same fucosylation is required for the H antigen. So when there's a defect, there is defect in both, and hence the child may have Bombay blood type and the LAD2.
So, can we use granulocyte transfusion as a treatment option in CGD?
That's not a viable option, because I mean it's a absolutely a constitutive defect. So even if you tide over one episode, you'll be only treating the infection, but you'll not be treating the underlying disorder.
So, the last question would be for a child with MSMD, if interferon gamma is given, what would be the prognosis?
So I mean, actually it depends upon the I mean, if it is, you'll have to decide whether you're giving it for. I mean, most of the patients who need interferon gamma only are the ones with partial defect, so they have milder disease. So probably the interferon gamma will help to tide over their infections, and like we use IVIG occasionally in patients, so the interferon gamma will help to clear the infections faster when combined with antituberculous drugs. So, and if you clear an infection, obviously the prognosis improves. But I haven't read, articles on how long these have been used and what is the outcome.
That is the last question, ma'am.
So, thank you, Kirti, and thank you, Amrita, and thank you to the audience for listening in carefully and asking so many questions. It has helped us to also, rethink and go back and read a little more. And I will take this opportunity to invite all of you to this conference in March, which is attracting a lot of faculty who have worked their lives on these disorders. And we will be happy to see you register and see you at the conference. Thank you very much. With this, we'll close the session. Hello, are we off the screen?
Yes, ma'am, we are off air.
Thank you.
Yeah.
Amrita, I
Ma'am,
hope you're okay.
I'm okay. I'm very sorry, ma'am.
No,
A
no, it's
sudden bout of cough is just came out.
no problem.
It's been going on for 2 weeks. It's just not stopping.
Are you taking some inhaler or steroids?
I've been taking Montec LC, but I think
No.
after the sudden prolonged talking, it just came off. I'm
Yeah, it
really
becomes
sorry.
dry. Yeah, it becomes dry, and then. No, but thank you. With all this, you've at least been read and kind of